Hi, everybody. My name is Hillary Johnson. I am an infectious disease epidemiologist with the Massachusetts Department of Public Health. And welcome to follow-up for positive COVID-19 cases and their close contacts. And this is going to be the training talking about contact tracing, index case interviews, etc. And to start today, we're going to begin with Emily Rowe from Partners in Health.
Great.
Take it away, Emily.
Thanks so much, Hillary. It's nice to meet everyone. This is Emily Rowe speaking. I'm one of the doctors with Partners in Health for a long time, and I'm really excited that you're all joining the team. So welcome. To orient you, this is the COVID-19 response. We know the guidelines are changing daily, and we're really excited to bring your energy and your motivation and your skill set on board to ensure that we can capture the best data on COVID-19 and act on it to help the people of Massachusetts respond to this. This entire program is really under the leadership of Governor Baker, and the Massachusetts is well positioned to be a leader in the US for this response. So I hope that is inspiring to you all today. Our goal is isolation of cases and quarantine of contacts until that strategy changes or evolves. First, I'll give you a couple slides just about Partners in Health. In case you don't know us, we wanted to make sure everyone's aware there's two waves of this. It is all part of that one big program and response under Governor Baker's team, but you are part of wave one of training hundreds of qualified and motivated individuals to make a difference in this pandemic. Wave two will be shortly on the heels of wave one, which some of you will also join. It's using the same processes, a slightly different software platform, but all the principles and processes are the same. And that's where Partners in Health is working to help with that. And that will hire several hundred people across the state as a response. So we're very thrilled you're joining in this effort, and we will see you soon. The next slide shows us a little bit just about Partners in Health, a very brief introduction. We're an international nonprofit or NGO. We're headquartered in Boston, and we work in many countries across the world. We are a social justice organization. So we are striving to make healthcare a human right for all people, starting with those who need it most. At its root, our mission is medical and moral and based on solidarity rather than charity alone. We often at Partners in Health talk about accompaniment, which is the core of our patient-centered care delivery. This means we're participating in the journey of our patients beyond medical care to ensure we're there for them until they deem it necessary. Accompaniment is driven by compassion and solidarity and not limited in time or scope. And so the work is centered around the needs of patients, and our actions are informed by their lived experiences. So this applies very much to your work, as you will be accompanying individuals who are impacted by COVID-19, either people who are infected by COVID-19 or their contacts, and working to reach out to them to make sure that they are okay and that we're protecting their family and friends from further spread of the disease. So we think this will make a really big difference in public health outcomes in Massachusetts. And so our main message is to thank you for your participation. The next slide just is a map that shows all of the places where Partners in Health works across the world. You'll see Boston is right there at home here in Massachusetts. So thanks so much, and I can turn it back over to Hillary for to guide us technically through the presentation.
Thank you, Emily. So like Emily said, welcome everybody. So today we're going to talk a little bit about contact tracing, how it's an effective tool, and then we're going to give you the skills and all of the other documents and everything that's involved in this whole process. So thank you for joining us. So as Emily mentioned, we're focusing on contact tracing. It's really this idea that contact tracing allows behavior change to happen. So obviously right now in society, people should be socially distancing and for the most part staying home as much as possible, but there is a distinct difference. This idea that if a public health entity contacts someone specifically and says, hey, you yourself have been exposed to a confirmed case of COVID-19, chances are that individual is going to take that a little bit more seriously. They're going to have an opportunity to get the information that they need regarding quarantine and how they should best practice that. And they're going to just be able to, really public health activities are going to just really be enhanced by having that extra behavior change tool by outreaching to someone individually, as opposed to the idea that all of us, of course, should be social distancing at this point in time. So we're going to talk a little bit about the basics of COVID-19. And so let's talk about the mode of transmission. So again, all of this stuff is changing, and probably by the time you're listening to this training, things will have changed as well as we learn more and more about this disease. But as of right now, early reports suggest that person-to-person transmission most commonly happens during close exposure to a person infected with COVID-19. Primarily respiratory droplets that are produced when someone coughs or sneezes, etc. So what happens is the droplets can land in the mouths and noses or eyes of people who are nearby, or possibly even be inhaled. There is this potential that there also could be small respiratory particles aerosolized in the air, but we don't exactly know how much that has to do with transmission and what percentage of transmission occurs due to that. But we do know that some individuals are capable of transmitting the virus up to 48 hours before their symptom onset. So we're really talking about this close face-to-face contact. We're not necessarily talking about things floating in the air and traveling far away at this point in time. So what are the clinical features of COVID-19? It really can vary, and as we've seen with our patients here in Massachusetts, the symptoms can be incredibly mild, or they can be incredibly severe all the way to death. Typically, symptoms appear about 2 to 14 days after exposure, and the most common symptoms that we see are fever, cough, shedding, and then if they're enhanced to more complications, more clinical complications, they could include acute respiratory distress syndrome, pneumonia, and sometimes even things like septic shock. So the incubation period for COVID-19, so how long from exposure to when people start to show signs of illness, estimates or average about 2 to 14 days. So for the purposes of the work that we do, we're going to be considering this 2-week period of time as key for everything going forward. So which body fluids can spread infection? Really and truthfully, we know an upper and lower respiratory tract specimen. So that's the coughing, that's the sneezing, that's the respiratory droplets. You know, there is some data saying that SARS-CoV can be isolated in blood, urine, and stool specimens. But we really don't know how much these other bodily fluids, such as urine, breast milk, semen, etc., are involved in transmitting the disease. So for the most part, we focus on this respiratory expulsion. So when is someone infectious with COVID-19? The onset and the duration of viral shedding and the period of infectiousness for COVID-19 is not definitely known like we know for some of our other diseases that we work on. You know, they've been able to detect the virus in the lower and upper respiratory tract for up to weeks after illness onset. And we know that also based on some of the information we have from other coronaviruses. But the detection of the virus itself does not necessarily mean that the virus is infectious and it's transmitting to other people. There is also this possibility for asymptomatic infection, but we don't yet know what role that plays in the transmission of COVID-19. And we have found some data that people are possibly infectious prior to symptoms. And so we've kind of expanded our infectious period to include the 2 days before symptom onset. And that's relatively new for us. However, we still don't know how large a role that plays in transmission, so it's just something to be thoughtful about. So how do people get tested for COVID-19? As of the time that we wrote this training, the primary specimen was a nasopharyngeal swab, and that's the specimen of choice. And it's this long, kind of plasticky specimen that goes up the nasal cavity all the way as far back as possible. It's very unpleasant for people that have had it done if they're doing it correctly. And that's so they can capture the virus back there. Earlier in this process, there were also more oral swabs being utilized, et cetera. But as of this point in time, when this was written, the NP swab, the nasopharyngeal swab, is the specimen of choice. And what they do with that swab is they do PCR testing, use it to detect the DNA of the virus itself. As of the point of this writing, there aren't additional really rapid tests or other types of blood tests or things like that available, but that's definitely changing. So probably by the time you're listening to this, there will be more rapid tests in the field. There will be alternative serology tests, blood testing, antibodies, et cetera, available, but right now, still the primary test of choice has been the nasopharyngeal swab and doing PCR testing. So one of the big questions that we get is, can people recover from COVID-19? People who recover, can they get it again? And the answer is ultimately that we do not know. And it's probably going to be a while before we get a lot of data to really definitively answer that question. There is, an assumption that certainly you have some at least short-term temporary immunity, and that comes into play for the work that we do. Certainly, if someone in the house is tested positive for COVID-19, and then their spouse later tests positive, chances are, you have a short period of time where that primary person would probably have some sort of immunity, and they wouldn't necessarily be getting it again right away from their spouse. But again, time will tell, and data will tell. So we refer to COVID-19 cases with positive labs as confirmed cases. So these are all the cases where we have an actual PCR result. We consider them confirmed. So that includes specimens that were processed at CDC, at the Massachusetts State Public Health Laboratory, and as more clinical and commercial labs and hospitals come on, those would be considered confirmed cases of COVID-19 as well. Now, the case definition will potentially change over time. For a lot of the other diseases that we work on in public health, we have more definitive language and definitions around clinically diagnosed cases. So that's cases where the doctor looks and assesses someone and says, yes, all of your symptoms are compatible with COVID-19, but they don't necessarily do a lab test. So there may be additional expansion to include ill patients with contact to confirmed cases but don't have test results, or there may be some positive antibody tests in the future. But as of right now, we're looking at laboratory confirmed individuals, and those are the people that we count as positive confirmed cases. Who can get tested for COVID-19? So testing started out only in the beginning of this pandemic, started out only available through CDC, and that was in January and February of 2020. In early March, testing expanded to also be available at state public health laboratories. As of this point in time, testing is currently being rolled out through commercial laboratories and also some larger medical providers. And like we said, it's expanding daily. So there are more and more people offering testing, even though it still can be difficult for people to access at certain points in time, depending on where you live. But the opportunities for testing are expanding a lot. Initially, there was a requirement that patients had to meet very strict testing criteria and be pre-approved, especially when testing was really limited and it was only available at CDC, and even when it expanded to being available at CDC and the state public health laboratories. But as of about mid-March, certainly in the state of Massachusetts, we published a clinical advisory that expanded testing guidance and kind of helped determine who should be tested and where to send those specimens, really giving the power to the providers and the doctors themselves. So again, who can get tested for COVID-19? So as of about mid-March, public health pre-approval for testing is no longer required. It certainly was in the beginning, which definitely created a large amount of backlog and concern about how people could get tested. Although not everyone who is presenting in the clinical setting will necessarily be tested, the decisions are made by the providers and based upon how the person is presenting themselves with their symptoms and also available resources for testing. So we have kind of taken this whole group of people and tried to categorize people that we consider priority for testing into a couple categories. Priority one here described as people that we want, that we would like to test because they're hospitalized and, trying to find out if they're positive so that we can reduce the effects of transmission within the hospital itself, and making sure that everyone in the healthcare system is protected. Priority two, we focus on people with high risk of complications from infection and making sure that we know their test results so that they can be appropriately identified and triaged. These are people that are incredibly vulnerable, so we want to make sure that they have the right resources that they need. Priority three are, as resources allow, testing individuals in the surrounding community of rapidly increasing hospital cases to decrease community spread and ensure health of essential workers. So people that are critical to the infrastructure, who aren't necessarily in the other categories, healthcare, first responders, other people that we really want to make sure that we're getting diagnosed, individuals with mild symptoms in communities but they aren't quite hospital, in communities that have high hospitalizations, but maybe the individuals themselves don't have hospitalizations. People that we are not prioritizing as of this point in time are people without symptoms. So in theory, a lot of the testing, certainly testing at the state labs and at CDC, is not validated for people who do not have symptoms. That doesn't mean that people without symptoms, people who are asymptomatic, haven't found tests and haven't been tested, but that is not the priority population that we're working on, looking at this point in time. So another term that you might hear if you've done a little investigation online, or if you're looking at CDC's guidance documents, is this idea of a person under investigation, a PUI. So a person under investigation, a PUI, is someone who's being investigated for possible infection with COVID-19. And a PUI is really a term that was used earlier in this outbreak, back when we were at that point where we had to do a lot of investigation and pre-approval on the public health side before someone could be tested, because testing was so limited and it was pretty much only available at CDC. So we did a lot of investigation on the front end, trying to determine if people had the appropriate risks, appropriate epidemiological background, and would qualify for testing. And we're not really using this term at this point. You know, at that point, it was really referring to people who are suspect cases waiting for test results. But now that there's a lot more opportunity for people to be tested, there isn't as much public health investigation going into researching someone prior to testing them, because there are more testing options and we're not working with really finite resources. So while a lot of the CDC literature online may refer to a PUI, so that's essentially a better term would be a suspect case. And going forward, we would talk about a suspect case, so someone who we suspect has COVID-19 and is maybe waiting for testing. And then we think of other terms that we use, such as confirmed cases and contacts, et cetera. So you won't really hear the term PUI as much, but I think if you look online, a lot of the literature surrounding COVID-19 will probably refer to PUI. So just wanted you to be aware of that. So who is considered a close contact? Well, we really define close contact as being within 6 feet of a COVID-19 case for a prolonged period of time, about 10 to 15 minutes while they were symptomatic, or again, in this 2-day period prior to symptom onset, where we are now also concerned about close exposures. A lot of close exposures can occur where people are caring for or living with or visiting people, or in the healthcare setting. And certainly Section B here talks a little bit more about people who come into direct contact with infectious secretions, and while not wearing the appropriate personal protective equipment. So gowns, gloves, masks, eye protection, that sort of thing. And so Section B here often refers to healthcare workers, because they're the ones that are kind of on the front lines. But really and truthfully, close contact could be anybody that has that face-to-face contact. So we're looking at your lunch buddy, your house buddy, your bus buddy, but not necessarily a large arena or something, or walking through a building. Two important terms that we really want to make sure that you understand are the difference between isolation and quarantine. And so we will be referring to these throughout this training and throughout the work that you do with cases and contacts. And so there really is a difference, because they're referring to two different populations. So we use the term isolation for symptomatic people. These are for your confirmed cases or your high suspect cases. And it's for people with symptoms, people who have a risk of transmitting the disease to others. So people who are in isolation are people who are ill. And the idea is that we're isolating them to prevent them from spreading the illness to others. So it lasts until the person is no longer contagious. So they should be in isolation until they are no longer capable of spreading that illness to others. So it's at least 7 days since the symptom onset. And, you know, in order to get out of isolation, they have to meet some criteria. And typically we say, again, 7 days since the symptoms started, and they need to have resolved, and they've gone at least 72 hours without a fever. And without any medication to help reduce that fever. And they need to have significant improvements in their respiratory symptoms. And we'll talk about this a little bit more, but the idea is that you're in isolation when you're a case until you are deemed no longer infectious to others, and you have to meet some symptomatic criteria in order to exit isolation. Then we have quarantine. So quarantine is really for asymptomatic people who have had an exposure. So these are people that are travelers returning from high-risk areas. These are people who we identify as being close contacts to a confirmed case. And the idea is that they have been exposed, and so we put them in quarantine and try and limit their exposure to other people on the off chance that they are incubating and possibly will develop illness, so that they, if they do develop illness, by the time they start to show symptoms or by the time they also become infectious, we've had them, quarantined away from other people. And so the idea is that will help to reduce any spread from that person. So it's catching it early, putting this person in a situation where they're not going to be having contact with others, and that if they do develop illness, then we may have been able to skip the idea that they would have spread it to other people before they found out that they were ill. Quarantine lasts for 14 days from the last date of exposure. And so you have a date of exposure up to, based upon that particular exposure, you could potentially develop illness up to 14 days after it. And if you can get through that 14 days without being sick, without developing the illness, you're in the clear and you are released from quarantine. And kind of the whole point of the work that we're doing, quarantine is definitely different than social distancing. Right now, everybody should be showing, exercising social distancing. The idea that you're trying to minimize your contact with other people. You're staying at least 6 feet away from people. You're working at home instead of going into the office when possible. A lot of schools have closed. You're doing your online visiting with other people, canceling and postponing large events, that sort of thing. And really everybody should be doing that. But quarantine is kind of taking it to the next level. So you are actually staying home and not going out. You're using a lot of hand hygiene, washing, et cetera, at home to make sure that you're not interacting with other people as much as possible. You're not sharing your towels and your utensils. You're not having people over to your house. And then within your home itself, you're maintaining that, also that 6 feet distance and trying to stay in your own space. And so it's a lot, it's kind of the next level of social distancing. And so that's the idea that when we reach out and we notify people that they've been a contact to a confirmed case, they're having, that they're going to exercise quarantine that much more than they would just generally, with the idea that we all should be social distancing. So through this training, we're going to talk about a number of key documents that will help you in follow-up of interviewing confirmed cases and identifying and notifying their contacts. So we have a COVID and the paper-based tool is just for you. I find that it helps me when I'm interviewing people just to have a little something on paper that kind of groups things together into different categories and helps remind me, and I can jot down notes, that sort of thing. There will also be interviewing scripts available, talking about different scenarios, et cetera, that Partners in Health has designed and will be sharing with you. And then we also have a close contact identification form. Again, just another form to help you when you then go down the list and you're talking with your index case. About who their close contacts might be that might need to be notified about the exposure. And this is just a tool to help you. You can put 5 different contacts on a page to kind of put as much contact information as possible to give you an idea that and then you can track them. Again, a tool for your use, not necessarily something that's required. You don't turn it in or anything like that. There will also be a REDCap, standard operating procedure and SOP for how you're going to enter all of your information into the REDCap database. And then we also have isolation and quarantine guidance documents. So this is the information and guidance for isolation. So this one would be something that you give to a case, and this one is quarantine. So this would be something that you would give to a contact. And this is just, these will probably change by the time you're involved with them. These are the documents that will help when you're talking to someone and you've completed your interview and saying, here, this is how you stay safe in your home. This is how you quarantine in your home and make sure that you're staying away from others. And this will give you some information and help identify how to make that work for you. Again, all of these documents are changing all the time, and certainly even this training itself is changing and evolving. As we learn more about this illness, recommendations are going to change as well. So we hope that you have patience with us and are aware that things may be evolving all the time. And certainly some of these tools may change too, as you decide that, or we decide too, that things are not necessarily, that things can be improved and evolved, or we're finding things are more effective if we do X, Y, or Z. So I just want to give you a little background on how COVID-19 follow-up has evolved. So really in the state of Massachusetts, around February, we started beginning with returning travelers, mostly from China, that were identified for quarantine. And that ended up certainly on our side at the Department of Public Health, where we were focusing a lot of our work. We would get lists from CDC of individuals that had returned, certainly from hotbed areas of COVID-19 in China, and then later expanding to all of China, and then additional countries following that. And then, so we'd identify those individuals, and because they had traveled from high-risk areas, we were asking them to quarantine upon their return to the US for 14 days. And we would monitor them for that 14-day period to see if they developed illness. At the end of January, we did have our first confirmed case of COVID-19 in Massachusetts, and that was travel-related, someone coming back to the United States who had traveled abroad. Then in end of February, early March, the follow-up volume kind of expanded, and we really started to see more cases. So we had started out, we were mostly following up on contacts, and we had our first case, and then all of a sudden we started getting a lot more positive. So our follow-up switched from focusing mostly on travelers and making sure that they're quarantining to actually following up on index cases, so confirmed cases here and their subsequent contacts. And now we've kind of evolved to a point where there is community transmission here in Massachusetts, but we are still trying to focus mostly on our confirmed cases and their contacts. So COVID-19 response involves local boards of health in the state of Massachusetts. So new positive labs create a novel coronavirus event in our state surveillance system called MAVEN. Local boards of health, which represent all of the towns in Massachusetts, can then see the new cases that show up in their jurisdiction, so their town or their area. The goal is that they conduct index case interviews. So index cases are confirmed cases, and touch base with them, make sure that they are isolating, answering their questions, collecting some secondarily, doing contact identification. So then figuring out who might have been exposed while this index case was infectious, and then doing the notification and follow up to those contacts and making sure that they themselves are quarantining. Also in this whole process, you may identify a number of additional exposures of interest. So things in particular, aside from that, close face-to-face contact that we're looking for, are medical appointments that someone may have attended while they were infectious. If they were in any high-risk settings, we want to identify that as well. So those consist of long-term care facilities, nursing homes, schools, etc. And we want to make sure that we're notifying that facility. Sometimes there are workplace exposures as well. And so it might be a situation where we can just notify the workplace and they can handle the notification itself. It just kind of depends. Also, and this is becoming more and more rare as people are reducing travel, but there's still a possibility that there could have been flights while someone was infectious. And so when that happens, we try and identify the flight that they might have been on, and we work with CDC and the quarantine station to do a notification. And what they'll do is they'll look at flight manifests, and then they'll go and notify people on the plane who might have been exposed and send in those notifications to the states where those people are from. So assistance at the local level, assistance is needed at the local level because cases are just really skyrocketing. So not local capacity. All of them have MAVEN access, which is access to our surveillance system. And certainly at this point in time, many towns have received too many cases to handle themselves. And certainly as this outbreak progresses, we're going to lose staff to illness or quarantine themselves. They may become ill, they may have other family members that they're taking care of themselves. So that has been a lot of the background and the idea that we need additional help, and that's where you come in. When local assistance needs are identified, these index cases and their contacts are going to be assigned to our volunteer corps follow-up. And this is a partnership. Data collected and entered by the volunteer corps will eventually be seen at the state and local by state and local public health staff. So make sure that when you're doing your work and you're doing your notifications, that you're updating your notes in REDCap as soon as possible. because that data will eventually flow back into the state surveillance system. And we want to make sure that everything that you do is in there. So there isn't duplication of efforts, and that everyone knows where a case is at in terms of follow-up. So let's talk about what we're doing in the process and how it starts. So it begins with confirmed cases that you'll be assigned through REDCap. One of the first things to do is to read if there are any notes available, and there may be preliminary information on the case from previous calls or follow-up, and there might already be some indication if the patient has been hospitalized or any sort of clinical summary. Of course, there might not be, so don't be surprised if there's some data missing. And certainly there may be just not enough information for you to contact somebody. So you may need to look at the ordering provider or where this person got their test done and call them if you don't have a patient's phone number or something along those lines. So you can consult a facility's infection prevention or the ordering provider to obtain hospitalization details or other clinical information. And since you have them on the phone, it doesn't hurt to ask if they're available and they have the ability to give you symptom onset dates or other clinical complications, hospitalization data, occupation, race, ethnicity, etc., if it's appropriate at that time. You want to confirm contact information, and then sometimes the patient may not be available because the patient may be hospitalized, and you might be the first person figuring this out. And that's totally fine, and that definitely happens. If someone is not if someone is hospitalized or it looks like they won't be able to be interviewed, you can obtain emergency contact information for conducting the interview. So I had that happen for a case the other day where someone was actually hospitalized, and so I obtained the emergency contact information for that individual's daughter and was able to interview her and make sure that contact tracing was happening by going through her. And the daughter was great in terms of helping me get the information I needed on the index case and identifying anyone who needed to be notified about potential exposures. So the follow-up for when you're actually talking to the case is you want to interview the case, and you can use the interview tool and the scripts that Partners in Health are providing. This document. You want to collect some demographic information. You want to make sure that we're getting all of the correct contact information, that we have race and ethnicity, things along those lines as well. Knowing what they do for work, that sort of thing is very helpful. And then you want to talk about clinical information. What symptoms did they experience? Did they have any underlying health conditions, hospitalization dates, things along those lines? We also want to know a little bit about their risk history, and that's really a conversation to determine if we can figure out where they themselves, the confirmed case, might have been exposed. Did they have a particular event they went to? Did they travel from a particular location? And that may be more of a conversation that you have with them. And then, kind of secondarily, we want to talk about identifying close contacts. So after you've gotten information and collected data on the individual themselves, then you want to talk about their contacts. And then you can use the close contact form to kind of go through that and identify anyone who might need to be notified about their potential exposure. You want to wrap up the conversation with the individual by answering their questions, addressing any concerns that they have. People often have questions. They want to know, they'll have probably a sample scenario for you or something and that they're worried about, and they want to know what the best course of action should be. So you can help guide them on that, either allaying their fears or helping them to figure out what the best thing to do would be. And then you want to also make sure that you're ensuring isolation is followed. So making sure that they have information on how they can best protect their family, anyone in their home, how they can best protect the community by staying isolated going forward until they're no longer considered infectious. And you can help guide them on that by giving them some information. Then you want to do contact notification. So you want to create because you've gotten now a list of contacts, you want to create the contacts events in REDCap. And then you want to do the notification. So you want to contact those individuals and notify them about their exposures. You want to instruct them about quarantine period and how long they should stay at home and try and avoid contact with other people. On the off chance that they are going to develop illness. And then you want to establish a follow-up plan if they do develop symptoms. So make sure they have a plan in place for tracking themselves and monitoring their own health during that 14 days. And then if they do notice that they're starting to feel ill, if they're starting to develop symptoms, that they have someone that they should call. They can call their provider and they know how to do that ahead of time. You want to answer their questions and address any concerns that they have, and then make sure that they're following their quarantine period. And then you want to give them the quarantine guidance document that kind of outlines that. So even though you'll have talked about it all with them, you want to then give them a piece of paper as a takeaway on how to make sure that they're staying safe and they're quarantining successfully at home. So how are cases notified that they are positive? This is definitely a question we get. So most medical providers receive the test results electronically from wherever they sent their specimens, and they should be calling the patients and letting them know that they tested positive for COVID-19. But there's certainly a volume issue at the moment, and not all providers are calling out the results right away. So there is a possibility that you, depending on how fast the system works, you might be the first person to notify a case that they tested positive, and that's okay. Public health is frequently the first to notify a patient. I do it all the time. Remember, particularly for this disease, people are waiting for these results and they want to know as soon as possible. And if you're the first person to tell them, they want to know the answer. So they're waiting for your call or someone's call to let them know what their test results are. So what should you tell the case when you're talking with them? So one of the first things you want to talk to them about is informing them that they should be under isolation immediately if they haven't already isolated from everyone else in their household. And isolation is really trying to stay not just in your home away from society, but also trying to distance yourself from your housemates, your family. You want to give them the isolation guidelines and then tell them that they should isolate until they meet criteria for clearing isolation. And the criteria for clearance could change, but it's currently based upon how their symptoms improve with a minimum of at least 7 days since their symptoms started, and they need to have a certain period of time where they have been asymptomatic before they could kind of re-enter their household, so to speak. They should have a plan in place for seeking healthcare if their symptoms are going to worsen, and they need to make sure that they call in advance so that wherever they're going to go is ready to receive them with appropriate precautions. And you can use the interviews tool and the scripts to kind of go through this whole process. Remember, the data that you're collecting in this interview is what is going to inform this outbreak. So and all the things that we're learning about this new pathogen. So when we learn how many people are hospitalized, when we learn what are the most common symptoms, it's coming from these interviews that you would be doing with these index cases. So we're really relying on your investigation and data collection on that index case. So use the interviewing tool to guide you. The first page of this interviewing tool really covers the information related to the confirmed case. So their clinical symptoms, their complications, and then kind of at the bottom talks about where they might have been exposed themselves. So we're really trying to determine risk, severity of illness, and if there are certain populations that are being affected by COVID-19 more. And we gather that from the information that's on this first page of this document. Now, the second page is really more for your notes, and you can use this in partnership with the interview scripts. But really, it's just giving you a reminder on what's considered close contact, so you can use that when you're discussing contacts and identifying contacts with your index case. And you're really trying to determine who should be notified based upon who the index case might have exposed while they were infectious. And it gives you some categories of different people to think about. So immediately starting with household contacts, and then kind of expanding other close friends and associates, and then identifying other places that might have had exposures and were they traveling, et cetera. And not necessarily every category on here needs a notification, but I think that these cover all the categories so that you can talk with that individual and really determine if there was an exposure or not, allay their fears maybe if there wasn't an exposure, but they're worried about there having been one, and answer their questions. So think of the second page as more of just like a guidance and kind of writing notes for your conversation about contacts. And then again, using this form, once you've decided that there are categories that you want to talk about, so if it's going to be household contacts and they had some workplace exposures, for example, then you can use this form yourself to just start going down and naming people and gathering as much contact information as you can so that you can then successfully notify those individuals. And you can put about 5 people on a page here. You're probably not going to be able to get all of the contact information for each person that's on here, but these are just clues and tools, different demographics that you could collect in theory that would help you do the notification. But some of the most important things on here are the last date of exposure and the quarantine period. So those are key things that if you are going to then notify somebody about their exposure, you want to make sure you know when they were exposed so that you can give them a quarantine period. All right, so let's take a look at that interview tool a little bit more. So the top part here is going to be the demographic information, and some of that is already going to be available in REDCap when the event is assigned to you. However, incomplete information is not unusual. So I guarantee you, in my experience in my many years of doing this, you're not going to have everything on there when you get this patient. So you're not going to have multiple phone numbers, email addresses, full addresses, et cetera, occupation, race, and ethnicity. But as much as you can, that's information that we want. Email address is particularly important because if you're going to be emailing them the isolation guidance document, that's how you can give them that information. So I guarantee you won't be getting an email address electronically from the lab report. That's something you're going to have to ask for. Certainly race, ethnicity, and gender can be sensitive topics, and so you may want to ask those missing variables after you've gotten a little bit going in the interview. But I will say this, if you are asking those questions in a hesitant manner or feeling like you really shouldn't be asking them, when you present that, you're going to also get that back. So people are going to say, oh, in the way that they're hearing it, this person sounds like they shouldn't be asking this question, so maybe I shouldn't be answering this question. So while they are sensitive topics, I want you to ask them confidently and clearly as part of the interview, and then you're more likely to get a successful response. And the information is really important because if this outbreak is affecting certain populations more than others, we want to know that. All right, so then we move on to clinical questions. Obtaining information on the patient's symptom history is definitely key. Do the best you can with a patient's recall and treat it more like a conversation. And I think it's most helpful to obtain general information and then go back and ask them specific questions about their, based upon their responses. So starting out with something like, do you remember when you first started feeling ill? Tell me a little bit about that. What was your first symptom that you remember? And then trying to get dates as well. And then certainly after they've told you a little bit of a story about their symptom history, then you can go back and say, oh, did you experience any chills? Did you ever experience any diarrhea? Did you ever experience any headaches? And then you can maybe go down your list a little bit and check mark things. Clinical complications that we really want to know about that are particularly important include pneumonia and acute respiratory distress. So that may happen a little bit more with some of your hospitalized individuals, but not necessarily. There could be people at home as well that have some of those clinical complications. Hospitalization locations and dates are important too. So the patient may or may not be the person that you're talking to if that applies to, but it could be. You may also be talking to someone on the phone while they are hospitalized, and they may still be able to talk with you. So it kind of depends. This question down at the bottom here, is the case a healthcare worker, is very important. So we want to make sure that we know that at some point. So where might the case have been exposed to COVID-19? So this bottom section down here at the bottom of this interview tool, there are questions here just to kind of help guide that, but it's really meant to be kind of a conversation, and these questions are not going to exactly match what's in REDCap. Instead, it's going to be a section that you can do some, add this to the notes, as well as maybe doing a couple drop downs and if there are certain things that are identified. But of all the things, this is something that's helpful, but it's not the most critical on this whole interview tool. But we would like to know if we can figure out where this person potentially was infected, and if they're, we know that they're a contact to a confirmed case, if we can link them back to somebody, or if there's a particular healthcare exposure that they had, and then they came home, and that was like the only place that they were, and then we can figure out maybe they were exposed while they were at that healthcare visit. That sort of thing will be helpful. Again, this is more of a conversation, but these are some leading questions on here that might help you in determining where this person might have become infected themselves. So how do you do the contact tracing investigation? So after you've kind of gone through that first page and you've really talked with that individual about their care, about their experience and what happened to them and how they're doing, then we want to think prospectively in terms of, are there any, did they have any close contacts beginning with the 2 calendar days prior to their symptom onset? You want to inquire about air travel, any high-risk exposures, and you want to give them information about what we consider a close contact. So really talking about that, close face-to-face contact, at least, within 6 feet or more. And we have had experiences where medical settings or medical doctors might have their medical provider might have a more conservative definition of what a close contact is, and that's fine. So just know that that's possible. They don't need to identify people that they had contact with prior to the 2 days before their symptom onset. So if it was like a week earlier or last month or something, people will be very concerned because they went to that birthday party or they did that thing. But figure out if that fits within the period of time of the 2 days prior to their symptom onset. And if it didn't, you can help allay their fears there. So when you're collecting information on the contact, you want to get as much information as you can, obviously, but you need to get at least enough to notify that individual. So you need a name, likely a phone number, an address would be great, but doesn't always happen, and the date of exposure. So not all index cases are going to know complete addresses of all their friends, but if you can at least get the town, that's definitely helpful, because that determines the jurisdiction that the case belongs to. And so when you put all that information back in and it goes back into REDCap and it goes back into the state surveillance system, that town nurse, that town public health agent would know that case is for them in their jurisdiction. So knowing the town is very helpful. Again, at least you might not necessarily get that when you're collecting information on the contact, but then maybe when you're doing the notification, you can get a little more contact information. You at least want to have enough information to contact somebody. So you at least need a name and phone number, or a name and an email address, or I guess a location too. So let's talk about determining the infectious period for a case. So you need to really try and drill down on the exact symptom onset date to determine an infectious period. Symptom onset date should be the date of the first noticed symptoms. So I would say most common that I've come across is the start of a sore throat, sort of a cough, or certainly if people measure fevers, but I think certainly in adults, sometimes we can feel a fever or aches and pains kind of coming on prior to actually measuring a fever. So sometimes that might be your point of reference. And so really talk with them and see if you can drill down a little bit and figure out what the first day was. We're going to consider 2 calendar days prior to onset until the last time that they had contact with others. So most likely when they entered isolation would be the period of time that we're looking at. Use a calendar and ask what the case did each day, and counting back 2 days from the onset of the first symptoms. I use a calendar all the time. That's probably the best tools that an epidemiologist can have on hand is a calendar. And I literally count out loud. So don't try and think like you need to do the math in your head. It's okay to count out loud and we'll go 1, 2, 3, 4. So symptom onset is going to be day 0. Infectious period start date is going to be 2 days prior to the onset. So day 0, and then going backwards is going to be 1, 2, and those 2 full calendar days. And like we said, the infectious period end date is going to be when the patient is released from isolation in theory. However, you're probably going to be talking with them, and if they have successfully isolated themselves, we're going to be going from the 2 days before calendar, before symptom onset, through their last contact with people. And that will be the period of time that you're looking at. So determining the infectious period, we'll kind of go through an example here. So symptom onset date is considered day 0 for determining when a case can exit isolation, et cetera. So you want to use full days, not times of day. In any of this work, don't get wrapped up in times of day. Considering we're going to look at full calendar days. And for example, this happens a lot. So say a case had a meeting in the morning, and then later that night they had their first symptom, like a sore throat at that night or something. That's fine. You consider it that day 0. Certainly people in the morning were exposed. That is the day of symptom onset. You don't have to worry about the times. Don't try and calculate hours or anything like that. Look at full calendar days. The day of the onset is the day that the symptoms started. So in this example, a confirmed case developed a cough in the evening on Thursday, April 2nd. So let's look right there. Symptom onset, we're going to count that as day 0. And then again, don't worry about time of day. It's really, we're looking at that full day. And then the infectious period start date is going to be 2 days prior. So we're going to consider day 0, day 1, day 2. So the full day of March 31st is going to be the day that, a day that we consider any exposures. If you want to know about any exposures there, and we would consider that person infectious on that day. And then the infectious period ends when the case is no longer infectious, but usually it's whenever they last talked with people is the time period that we're going to look at. So if this person, you know, develops symptoms on April 2nd, we'd start looking at the 2 days prior, and then we're going forward. And let's say they didn't find out about their test results and they didn't start isolating at home completely away from other people until April 8th, so day 6. So we're going to say, okay, we know that going forward you're isolated. We're not going to worry about any other dates, but we're really going to look at starting March 31st and going through April 8th, and we're going to go through that period of time. All right. All right, you can likely just go with when they isolate and they don't have any contact with other people going forward. So determining the quarantine period for a contact is going to be based upon those particular exposures. So this is a different example, so don't necessarily think it has to coincide with the previous dates. But so you must identify an exposure date to determine a quarantine period, and that exposure date is going to be called day 0 in terms of your accounting. So quarantine period is day 1 through the end of day 14, and the idea that you could return to activities on day 15, again, using full calendar days. So look at this. Someone was exposed on March 29th. We're going to consider that day 0. So the quarantine period is going to be the next day, day 1. So that's March 30th through 14 days later. So that would be April 12th. And then quarantine is over on day 15. And so April 13th. So you need to stay quarantined through that full 14th day, returning to normal activities the next day. Have a calendar handy, count the days out loud, use full days, not times of day. And then the contact will likely already be in what should be their quarantine period by the time you're contacting them. You know, it's a great, it would be a perfect world if we were contacting them on March 30th, day 1 of their quarantine, and saying, hey, you got exposed yesterday and you need to quarantine for 14 days. But chances are it's going to be further down in the process. Chances are you're going to be a couple days in by the time you're notifying them. So make sure that they're starting to quarantine right away, because they're probably a few days into when they should have already been at home quarantining. And hopefully they are, or they had minimal contact with other people, but you never know. So just know that their time is of the essence in doing these notifications. So what do you do about the contacts? You want to input the contacts into REDCap. Make sure that there's enough location information that another volunteer could contact them. So if you're not the person that's going to be doing the notification to the contact, make sure you put in enough information that somebody else could do it if they had only the information that you provided. Make sure the exposure date is included so that the quarantine period can be defined. It doesn't really help anyone to contact them and say, hey, you've been exposed to a confirmed case. I don't know when it happened, but you should quarantine for an indefinite period of time. That's not really helpful. So you got to try as hard as you can, even if it's an estimate, to figure out what their quarantine period should be. So you notify the contacts that they have been exposed to a confirmed case and need to enter quarantine for 14 days from their day of exposure. If they're currently symptomatic by the time you're talking to them, make sure that you refer them in for medical assessment. They may already know, certainly with everything going on, or if the index case had notified them, they may already be in the know. But this is an opportunity to make sure that they're getting what they need and answering their questions from a public health person. Make sure that you give them the quarantine letter or whatever document we end up providing through this program, and advise them that they should actively monitor themselves. They're in charge of monitoring their self for changes in health status, et cetera, et cetera. And recommendations for how to do that are monitoring their temperatures, noting if they're starting to develop a cough or shortness of breath, sore throat, muscle aches and pains. And just having you outreach to them will likely make them that much more aware of anything coming on. And they should have a plan in place by the time you end the conversation with them on how they would notify their provider at a later date for an assessment if they ended up needing to do that. So managing contacts. You want to prioritize the household members and close contacts, and they should be quarantining away from your index case that you're interviewing to prevent recurring exposures. So you don't want it to slowly go through the household, over and over. So really and truthfully, as soon as someone becomes symptomatic, the ideal world is that they're isolating away from the others. And sometimes you can partner with your index case, your confirmed case, and to help in the notifications. Certainly if there's a large list of people that need to be notified, working with them, they may have already done some notifications, or they might need a little bit of help, and then they want to do the notifications. You just need to give them some information about what they should be saying and what they should be advising their friends to do. You want to prioritize high-risk settings or settings of interest. So long-term care facilities, nursing homes, doctor's offices, schools. Schools are typically closed at this point in time, but you never know. But think of these high priority areas, and we want to make sure that notifications go to them as soon as possible. If you identify a setting where numerous exposures took place, like a work or a conference or a camp or something, it may be something that it's easier to work with your supervisor or the local Board of Health or Department of Public Health, and then we can help notify the organization. And then it may be something where the organization would send out a general notification so that you don't have to contact all 30, 40 people that were at a meeting for whatever reason. If they're still having these large in-person meetings, which they should not be, but you never know. So work with your supervisor and us, and we'll figure out a notification plan if there's an odd scenario like that. So when is isolation over? So when you're talking to these cases, they're going to want to know when they can kind of return to their normal activities, when they can come out and be part of their household again. And there are a couple ways to determine that. One of the ways is using symptoms, and this is called the non-test strategy. And it should be applied to people who test positive for COVID-19, and certainly anyone who's clinically diagnosed with COVID-19 and didn't get tested but is assumed to be a case. So symptomatic people with COVID-19, either lab confirmed or clinically diagnosed, who are in home isolation may discontinue the home isolation under the following conditions. So you kind of have to check mark these. So has it been at least 3 days, at least 72 hours passed since they've recovered? So recovery is defined as the resolution of fever without using any fever-reducing medication. So they haven't had a fever and they weren't using Tylenol to not have that fever. They were just fever-free naturally. And they've had improvement in their respiratory symptoms. So their cough or their shortness of breath has gotten considerably better. So one of the questions happens here is, some people get coughs and they have coughs. They're a 4-month cougher. Like every time I get a cough, it lasts for months. And so that's not necessarily what we're talking about. But if someone had a really bad cough as part of this illness, it needs to have markedly improved. Not necessarily gone away completely, but markedly improved such that they can tell that there has been a dramatic improvement, and now they're just coughing occasionally every once in a while. That would be considered that they've had respiratory improvement. So they've had at least 3 days of no fevers and respiratory improvement and any of their other symptoms. They've either gone away completely or really are on the mend. So that's step one. And then at least 7 days have passed since their symptoms first appeared. So their illness onset date, that day 0. So it is possible, certainly for people that have lesser symptoms that don't get COVID-19 too badly. So maybe they're sick for like 2 or 3 days and their symptoms go away. That's absolutely possible, but they should still isolate. That's why we say a minimum of 7 days. So for those people who recover very quickly, they're going to meet that 3-day threshold. If they've not had a fever for at least 3 days, they're going to meet that fairly soon, but we still say that they should isolate for at least a minimum of 7 days. So everyone who has COVID-19 should be isolating for at least 7 days. And then any longer than that is based upon if their symptoms have resolved. All right. So when is isolation over? Another option is to use testing. So we just talked about a non-test-based strategy. So initial guidance from CDC required that people have 2 negative PCR tests at least 24 hours apart after they resolved all their symptoms. And that's definitely still an option, and some people may use this. They may seek additional testing and test negative 2 times and then be released from isolation. but it's not a very sustainable approach, and certainly with resources that may be limited for testing, requiring every single person that gets infected to then also to have additional testing, at least 2 negatives. It's not feasible for everybody. So that's why there was that clinical guidance based upon symptoms also developed, and it's probably going to be the path of choice. All right, asymptomatic persons. So when is isolation over? So again, people who have no symptoms shouldn't necessarily be seeking testing, but we do know that that has still happened, and we have had people test positive who had no symptoms. So you can't really use the symptom-based strategy for releasing them from isolation. So if someone tests positive for COVID-19 and they didn't have any symptoms, they still need to isolate. People who are lab confirmed with COVID-19 infection and don't have any symptoms, they need to isolate at home for at least 7 days since the date of their test, and they've had no subsequent illness develop. So if someone's asymptomatic, they test positive, they're required to isolate for 7 days from the date of their test, and make sure at the end of that, if they haven't developed any symptoms, then they could be released from isolation. So again, this is a rare scenario, but it is something that we do get questions on because people without symptoms have made it into the testing pool, and some people have come back positive. So the non-test-based strategy is probably the most practical. So the idea of looking at people's symptoms and then deciding based upon their symptom resolution that they could then exit isolation, it's probably the most practical. However, there are some situations that we've come across where workplaces might also request a test-based strategy, and that's fine, go with that. Pick a strategy and go for it, basically. So if, for example, someone was released on a non-test-based strategy because their symptoms had resolved, and then for whatever reason they went and got a test, and their test came back positive, I don't recommend going and getting testing if you've already been released for isolation, but it is possible. They could then at some point in time have a positive test. So we've gotten this question. So what happens if they've already been released because their symptoms resolved, and then for whatever reason their work or someplace asked them to get another test and the test came back positive? So they've now set themselves up where they need to isolate for 7 days after their last positive test. And then if they go for another 7 days after that test, maybe even going back into isolation because they were already cleared, but they decided to get this test for whatever reason, if they got a test, they need to stay isolated for an additional 7 days after that. And as long as they have no additional symptoms, then they would be cleared. So try not to mix and match strategies. If you pick a strategy, go with it, and then you'll have it's easiest. Otherwise you get into these tricky situations. So let's talk a little bit about some of these frequently asked questions that we get for quarantine. So if someone is in quarantine, is their family quarantined as well? And technically the answer is no. Their family members are not quarantined as long as the quarantined individual, remember, they're not a case, they're just someone who might have been exposed. If that quarantined individual remains asymptomatic, if the quarantined individual develops symptoms, then they must immediately isolate from their family, and their family is now under quarantine because now their family is close contact to a symptomatic person. So what the best thing to do is when you're notifying someone that they should go into quarantine because they may have been exposed, advise them to also try and reduce their exposure with their family as much as possible. On the off chance that they are going to develop illness, then that way we can help reduce the impacts on the rest of their family. If someone in quarantine tests negative, how long must they stay in quarantine? So the answer is, so for example, you've got somebody that's in quarantine because they've been exposed, and let's say like 2 or 3 days in, they start to not feel great. They go and get a test, and the test comes back negative. They still have to stay in quarantine for their full 14-day period because it's possible that maybe the symptoms that they had weren't COVID related. They just had a cold or something. And because we know that COVID-19 could still develop up to 14 days after exposure, they could still develop COVID-19 at a later date based upon their exposure. So maybe they're still incubating. And so we would ask in that particular case, if they had a test earlier in the process, it doesn't clear them because we still know they could develop illness within this 14 days. So yes, they still have to stay quarantined for their full 14 days. How long do household contacts have to quarantine? So through 14 days after their last exposure to a case. So if you have a confirmed case in a household, and the family is quarantining because they are close contacts, particularly close because they're household contacts of confirmed case. The gold standard is really that your confirmed case is isolating away. So once that person develops illness or they become a confirmed case, they're cutting off contact from their family. And that would be considered the last date that the family was exposed. And so if they are able to do that successfully, then the family can start counting their 14 days of quarantine. But there are situations where people don't have the ability to separate themselves from their household. And if that's the case, the family members are being routinely exposed daily as that person goes through their illness. So they can't really start their 14-day quarantine period because they keep getting re-exposed. The idea is that their 14-day quarantine period is going to start the last time they're exposed to an infectious individual. And if they couldn't separate, that means this person, the index case, has to go all the way through their illness, get to the point where they're out of isolation, they're no longer infectious, and then that starts the 14-day period of time because that's the last exposure for the family. Okay, so this, again, what about children of people in isolation? Children should remain quarantined away from the case to prevent exposure, but this isn't always possible in that scenario that we were just describing. So certainly children, if they can't completely separate from the parent who tested positive, they have to restart until, they'll restart their 14-day period once their last exposure to illness happens. So once the parent finally is no longer considered infectious, that 14-day period will start. So it could potentially go on for a while, in all honesty. And so another question we get is, what about contacts of contacts? So you do not need to investigate the contacts of asymptomatic contacts. So when you're doing a notification to someone, you're letting them know that they were potentially exposed and they should quarantine, and they say, oh no, I saw my neighbor the other day. Well, as long as they themselves are asymptomatic and don't develop illness and aren't a case, then we're not worried about that neighbor. We don't need to go notify the neighbor that they're a contact of a contact. We're really looking at people who are contacts of cases. So think of it that way. Unless the person you're notifying becomes a case, we're not worried about their subsequent contacts. So what if a contact develops symptoms? Well, this is what you want to prepare for when you're talking with them. They should consult with a medical provider to determine if an assessment is right for them, and they should isolate from everyone while symptomatic and awaiting test results. So the idea is you're notifying somebody, you're saying you may have been exposed to COVID-19, a confirmed case of COVID-19, we want you to quarantine. If you start to feel ill, definitely call your provider. And certainly the second you're starting to develop symptoms, making sure that you do not have contact with other people while you wait for your test results. So what if the test comes back negative? So we talked about this a little bit, but again, if a person under quarantine tests negative, they still need to complete their quarantine until, in the event that COVID-19 infection actually was going to happen a little bit after they got tested. So it's definitely possible. Tips for interviewing confirmed cases. So when you're talking to people, you really want to treat it like a conversation. So don't go line by line in the interviewing tool. And there's certainly scripts that will help you, but they cannot prepare you for every situation that you're going to be talking about. So being empathetic is really important, and trying to capture several pieces of information at a time in one section, by having an open-ended question that kind of starts the dialogue, asking them to talk about their symptoms, and then you can kind of go back and fill in the gaps with additional questions going forward. When they ask you questions, if you don't know the answer, that's totally fine. Be honest about it and say you'll get back to them. I definitely do not know the answer to everything. I get back to people when I can, and I'm really honest about it. So make sure that you take an email address, or you have the best number to call them back, and then talk to your supervisor or DPH, and we will help facilitate an answer in whatever you need. All right, so this is about wrapping it up here. We want to make sure that you know who you can contact. Andy at Partners in Health. You can also call the Massachusetts Department of Public Health Epidemiology Division. That's our main number here, and you'll get an epidemiologist like myself to help you to answer questions. If you have questions about the surveillance component of things, or entering, or any sort of informatics related, definitely call our Office of Surveillance and Informatics, and the number is there. All right, and so I'm wishing you good luck. If you have any questions, definitely send them to your supervisor or talk to us, and we'll go from there. But we are really excited about your work, and we are looking forward to having you join the team. So thank you very much for listening to me today. Bye-bye.